Good evening, sir. Dr. Ashwin, sir. Good evening.
Good evening, sir. Rishikesh, sir.
Good evening.
We are live.
Yeah.
We are live.
So, good evening, everyone. So, we are back to yet another Wednesday webinar, and this is the fifth in the series of Vidarbha Ophthalmic Society series of Wednesday webinars. And it is my pleasure to welcome you all for today's Neuro-ophthalmology insights that we are conducting with Gondia Ophthalmic Association. And we are delighted to have with us distinguished national guest faculties, Dr. Shikha Bassi Madam and Dr. Rashmin Gandhi, sir. I express my sincere gratitude to our dynamic President, sir, whose constant guidance and encouragement has been the driving force behind all our academic endeavors. I request our President, Dr. Viral, sir, who has been driving force, to give his opening remarks, please.
Thank you. Thank you so much, Dr. Rahul, Chairman Scientific Committee of VOS. So, welcome everyone. As we all know, this is the 50th year of our Vidarbha Ophthalmic Society. So, we are in the Golden Jubilee year, and fantastic work is being done by our scientific committee to have a webinar on every alternate or Wednesday or every third Wednesday. So, in today's webinar, Neuro-ophthalmology Insights, I welcome our national faculty, Dr. Rashmin Gandhi and Dr. Shikha Bassi from Hyderabad and Chennai, respectively. I also thank Gondia Ophthalmic Association for being co-partner with us for this webinar. Thank you, President Dr. Nilesh Jain, sir, and Secretary Dr. Aparna Gupta and the entire team. Thank you to our chairpersons, Dr. Shubhangi Madam, Dr. Varsha Pandey Madam, Dr. Mamidwa, Dr. Pradeep Agrawal, Dr. Rishikesh Mai, and moderators Sarang and Varda. So we have also been joined by our eminent panelists, Dr. Mohan Bhaimare, Dr. Deepak Navkhare, Dr. Garima, Dr. Samir Ambadekar, Dr. Shilpi, and Dr. Jayant Kavaskar. So, without wasting much time, I hand over the mic to our floor to our Chairman Scientific Committee for further proceedings. Before just signing off my address, I would request everyone to block your dates for 10th and 11th of January for our Golden Jubilee annual conference in Nagpur. So, it will be held on 10th January and 11th January, and we will get the details soon. Thank you so much, everyone. And over to Chairman Scientific Committee.
Thank you, sir. Without wasting time, we let us start the scientific discussion.
I think, Sir Rahul,
over
I
to-
think
yeah.
Rahul, if we can have some words from the President of Gondia Ophthalmic Association before
Yeah.
we start.
Yes, sir. Yes, sir. Nilesh, sir, requesting.
President of Gondia Ophthalmic Association.
So on behalf of Gondia Ophthalmic Association, this is the first webinar we are taking with the Vidarbha Ophthalmic Society together, and I hope that it will be a very fruitful for all the members. And please continue, Dr. Rahul. Yeah.
Yeah. So over to Shubhangi Madam and Varsha Pandey Madam and moderators for further proceedings. Yes, Sarang and Dr. Varda.
Yeah, so without wasting time, I think we are eager to hear all the speakers. It's my pleasure to introduce our first speaker, Dr. Nilesh Jain, who is the current president of Gondia Ophthalmology Association. And he has done his post-graduation from GMC Nagpur and DNB from Arvind Madurai. He has organized and participated in many national conferences. And he loves biking and mountaineering also. And today he is going to talk on interpretation of visual fields in neuro-ophthalmology. Over to you, sir.
Yeah. I'm sharing my screen. Yeah. Everyone able to see the screen, my screen?
Yes, sir. It is visible.
Yes.
Yes, sir.
Okay.
Perfect.
Yeah. Okay. So today's my topic is visual field interpretation in neuro-ophthalmology. And before starting my presentation, I would like to extend my gratitude to Vidarbha Ophthalmic Society for giving this opportunity. And before starting, it is always important to know the anatomy of the visual pathway. So as we all know that visual field is formed by the right eye and left eye together, and the right eye, the nasal fibers as well as the temporal fibers, they together form the visual field. Visual field can be divided into right hemifield, left hemifield, superior and inferior field, as well as the central macular field. These nasal fibers and temporal fibers together with macular fibers leaves the eye and exit from the optic disc and forms the optic nerve. The almost 53% of the nasal fibers along with the 47% of the temporal fibers, they run together in the optic canal and reaches the optic chiasma. In optic chiasma, the nasal fibers, they decussate on either side. And when they are decussating in the optic nerve, they forms a loop in the opposite side of the optic nerve, and then they exit from there in the optic chiasma and forms the optic tract. So in optic tract, the ipsilateral fibers of the temporal fibers and the contralateral nasal fibers are together, they forms the optic tract. Here, the fibers are not very much aligned each other, resulting in any lesion occurs in this area will going to cause the incongruous type of hemianopia. From here, the fibers reaching to the lateral geniculate nucleus. This lateral geniculate nucleus is having a dual blood supply, and here the fibers are getting terminated. From here, the new fibers are synapses, and then they reaches to the occipital cortex. Now coming to the lateral geniculate nucleus, the fibers, they form the two different bundles. The inferior fibers from the lateral geniculate body, they having a superior retinal, they are having a superior visual field interpretation. They forms the Mayer's loop and reaches the temporal lobe, and from there it reaches to the occipital cortex. Similarly, the fibers which the superior fibers which carrying the inferior visual field, they are reaching to the parietal lobe. From there it reaches to the occipital cortex. Now coming to this is the diagrammatic representation of the occipital lobe. In the right occipital lobe, the ventral aspect, you can see the representation of the foveal fibers or macular fibers are here, is exactly at the tip of the occipital lobe, which is having a dual blood supply from the posterior cerebral artery as well from the middle cerebral artery. And anterior to that will be the peripheral fibers will be there. Peripheral visual representation is there. Now, I'll just show you the left side. There is a different type of lesions which is present over the visual pathway, and the right side you will have a different type of visual field defect because of these lesions. So if there occurs any damage to the optic nerve of the right eye, will going to cause the defect in the complete loss of field in the right eye. Similarly, if lesion occurs in the optic nerve ending at the junction with the optic chiasma, if occurs a damage here which resulting in a junctional scotoma. This junctional scotoma will be comprised of total field loss of the right eye and the upper quadrantonopia of the left eye. Why it is so? Because here, as I told you, the anterior knee of Willebrand, which means the opposite side nasal fibers, they are crossing to the opposite side of the nasal optic nerve, and from there it reaches to the optic tract. So if this get compressed, which is resulting in a superior type of quadrantonopia. Then another condition is called as junctional scotoma of Trachor, which is very rare. In this, if tumor causes compression exclusive on the nasal fibers, which resulting in a damage to the nasal fibers of the right eye, which causing temporal field defect exclusively in the right eye, but the left eye will be normal and the nasal side will be normal. Then coming to the chiasma. So in chiasma, like 80% of the population, the chiasma will be sitting exactly over the pituitary fossa, but in 10% of the cases it will be prefixed, or in 10% cases it will be postfixed. In prefixed condition, the optic tract will be lying over the pituitary fossa, and in the postfixed condition, the optic nerve will be lying over the posterior fossa. Now coming to the optic chiasma. So if any tumor which is going to compress from the above or from the below will resulting in a bitemporal hemianopia. But how it starts, like in case of craniopharyngioma, if it is compressing, it will going to compress the superior nasal fiber first, which resulting in having an inferior quadrantonopia, and then as it progresses further, which resulting in a complete bitemporal hemianopia. Similarly, if there occurs like if there is a tumor in the pituitary area, which is going to compress the inferior nasal fiber first, which resulting in a superior quadrantonopia, and as it progresses further, which resulting in a bitemporal hemianopia. Now coming to the optic tract. So as I told you, the fibers are not aligned to each other, which resulting in a right incongruous homonymous hemianopia. Another important thing to be learned here is the ganglion cells which are coming from the eye, from the retina, it extend up to the lateral geniculate nucleus. Till here, if any lesion occurs, which resulting in an optic atrophy. While from the lateral geniculate body, the new fibers radiation, new fiber release, if damage occurs from this area to the occipital cortex, will not going to cause optic atrophy. Now, in lateral geniculate nucleus, that is, it is also supplied by the anterior choroidal artery as well as posterior choroidal artery. So, if there is occurs a occlusion to the anterior choroidal artery, which resulting in a superior and inferior VOS defect, but the central area will be clear. But in case of posterior choroidal artery occlusion, there will be a central field defect, but the superior and inferior part will be clear. Now, this is a diagrammatic representation of the right side of the ventral aspect of the right side of the occipital lobe. Here, you can have a lateral geniculate nucleus and lateral geniculate body. From here, the Mayer's loop means the fibers, inferior fibers, which is having a superior field interpretation. If any lesion occurs here in this area in the temporal lobe, will going to cause a pie on the sky, means a superotemporal defect. Similarly, if there occurs a damage to the Baum's loop, means the superior fibers which carrying the inferior field interpretation, which resulting in a damage to the pie on the floor. Similarly, if main radiation which is present in the parietal lobe, if damage occurs in this area, will cause a complete homonymous hemianopia. Now coming to the occipital cortex, so visual cortex. So in occipital cortex, if you see the base or the tip of the occipital area which is having a macular supply, so if any damage occurs to the posterior ciliary artery, will going to cause damage to the peripheral fibers, means anterior part of the fibers will involved, while the macular fibers will be spared. So that will be having a macular sparing type of homonymous hemianopia. And if damage occurs to the tip of the occipital lobe because of the head injury, which resulting in a congruous type of macular defect, but the peripheral field will be spared. So this is all about the lesion of the visual pathway. Now coming to the different diseases of the neuro-ophthalmology, like in case of anterior ischemic optic neuropathy, you can have an inferior altitudinal field defect, as I have shown here in the diagram, and few conditions which won't respect the vertical meridian. This is the condition. Yeah. Now, benign intraocular hypertension, in this there will be enlargement of the blind spot. Then another condition like toxic optic neuropathy, nutritional optic atrophy, or hereditary optic neuropathy, there will be centrocecal or central scotoma. In case of optic neuritis, there won't be any specific type of visual field defect. It would be altitudinal defect, diffuse loss of field, or there will be central paracentral scotomas also. An important thing to remember here, when we order for the visual field, it is always advisable to order 30 days too, because it tests even points more in temporal and nasal areas, which detect the nasal temporal defect easily. Along with that, in few conditions, we have to order 10 days too also, especially in case of bilateral papilledema or partial optic atrophy, in which the 64 points of the 10-degree field will be assessed or detect, which easily detect the central or centrocecal scotomas. Thank you. Have a colorful Navratri.
Yeah, thank you, sir, for finishing well in time. And it was a very nice overview of all the visual fields, especially in neuro-ophthalmology. So I would request the panel, can we have the panel discussion later and we can have the presentations going on? Rahul?
I think it's, if we can just have after each talk, it's better. Just quick
I think the schedule
discussion.
we have mentioned panel discussion at the end. So
Okay,
maybe we can go ahead with
and
the
have it late.
next talk. I would like to ask Vardha to introduce Dr. Shikha Basi for our
Yes,
next.
sir. Hello, am I audible?
Yes.
So it's my pleasure to introduce my teacher and mentor from Shankar Nethralaya, Dr. Shikha Basi, who is a Deputy Director of Neuro-ophthalmology Services at Shankar Nethralaya, and she's a dynamic cataract surgeon too. She's a recipient of SD Athavale Award at APAO 2013 and Best Poster in Cataract Catalyst in 2017. She has been organizing secretary for national and international conferences in cataract and neuro-ophthalmology and has given numerous talks in national and international meetings. She is a reviewer of many journals and has also published in many national and international index journals. Today, she will be talking to us on OCT neuro-ophthalmology.
Vardha, I'll just take 1 minute to just say that I can't think of anybody better in India to talk about OCT neuro-ophthalmology than Shikha, because she has done this so wonderfully well. And also, she is currently now the director of neuro-ophthalmology at Shankar Nethralaya. So, yes, please go ahead.
That's great.
Thank you, Aditi, sir.
Over to you, ma'am.
So at the outset, I would like to thank Vidarbha Ophthalmic Society, especially Dr. Rahul, Dr. Viral, for inviting me to give this talk on optical coherence tomography in neuro-ophthalmology. So this technology was born in United States at MIT in early 90s. And it's very similar to obtaining images with an ultrasound B scan, but instead of ultrasound, OCT is based on low coherence interferometry, typically employing near infrared light. The power of this technology, as we all know, is in giving us cross sections of the anterior and posterior segments of the eye, and it's a non-invasive, non-contact technology. Now, all we know, all we need in neuro-ophthalmology is to look at the structure of the optic nerve head, which can be seen beautifully up to the lamina cribrosa in EDI-OCT. We need to look at the health of the retinal nerve fiber layer, which can be seen by peripapillary retinal nerve fiber layer thickness analysis. We need to know the health of the ganglion cell at the macula, which can be studied by using macular ganglion cell inner plexiform layer thickness analysis. Now, what are the protocols that are required in neuro-ophthalmology? As I said, we need the peripapillary RNFL thickness analysis, which is obtained by getting a circular cross-sectional retina scan at a diameter of 3.4 to 3.5 millimeters centered around the optic nerve head. When you use the spectralis machine, you get this kind of printout. You get the averages in 4 quadrants. And in Cirrus machine, you get the printout like this. Again, the averages not only in the 4 quadrants, but 12 clock hours are given. In Cirrus machine, typically optic disc tube 200 into 200 scan is ordered. Now, the protocol used for getting the macular ganglion cell inner plexiform layer thickness analysis, typically these machines require retinal layer segmentation if you need to do the this particular test. And in case of spectralis, you get the actual ganglion cell layer thickness, whereas in Cirrus machine, you get a combined value, that is macular GCL as well as macular IPL thickness, which is given together. This is a printout from spectralis machine where you get a circular scan around the fovea. In case of Cirrus machine, it's an elliptical printout around the fovea, and the vertical radius is 2 millimeter, horizontal radius is 2.4 millimeter in case of Cirrus machine. Now, how to read these scans? Now, let's look at this printout from the Cirrus machine of the RNFL map, thickness analysis map. So here on the left side, we get the contour of the RNFL thickness in the eye. So this shows the warm colors like yellow and orange. They show how, they show the thick areas of RNFL, and blue color or the cold colors represent where the RNFL is thin. Then we have the deviation map. The deviation map shows how different the RNFL thickness is from the normative data or from normal people. We also get the parameters of the optic nerve in terms of the disc area, CDR, and the cup volume, etc. Along with that, we get the tomograms across the optic nerve head, both the horizontal and the vertical. And the RNFL circular tomogram is actually that 3.4 diameter circle that we spoke about. So that has been represented linearly here. We also get the NRR thickness and the, as I said before, the clock hours and the quadrant averages RNFL thickness. Now, how do we read the GCC scan? The printout, if it's given like this from Cirrus machine, again, yellow, orange color represents very thick, healthy GCC around the fovea. Around at the fovea, it's all blue. That is, it's not there. GCC is not there, as in periphery too. Adjacent to that is the deviation map again, which shows how different it is from the normal patients or normative data. There isn't much color here. That means it's very similar. It is normal. And we also get the averages in the 6 sectors. We get the cross-section across the macula too. Now, before you use that OCT in your patient, just be sure you're going to depend on this investigation. So look for artifacts. There shouldn't be artifacts because of poor signal strength, poor tear film, motion artifacts, segmentation artifacts, mirror artifacts are seen in highly myopic eyes. Now, coming to the clinical conditions where OCT has been used in the clinics. Now, a patient of optic neuritis, what's going to happen is because of the inflammation, there is going to be exoplasmic flow stasis. Even if there is no papillitis, you will see some amount of optic nerve head edema, which shows up as thickened RNF, peripapillary RNFL on the RNFL map. Now, over 4 weeks, it sets into thinning, and the sectors which are becoming thin, they're going to tell you whether it's typical or atypical optic neuritis. If it is the superior and inferior sectors which are thinning out, it's shown that it's more associated with severe form of optic neuritis, that is NMO spectrum associated optic neuritis. But peripapillary retinal nerve fiber layer thickness does not correlate exactly with the visual function, whereas the GCC thickness actually correlates with the visual function, that is the visual acuity as well as the visual fields. And importantly, the GCC thinning occurs, very severe thinning occurs in patients with NMO spectrum disorders, that is in atypical optic neuritis. Now let's look at some clinical examples. I've shown patients with typical optic neuritis or MS optic neuritis on the left side. Right side is NMO spectrum disorder or atypical optic neuritis. The RNFL scan from the Cirrus machine. Patient has right eye optic neuritis. As I said, there is some amount of thickening that is expected in the right eye, which is seen here. But what we see here is there is some amount of thinning in the other eye too. It's showing me that the patient has had an attack in the past. Now, a neurologist can use it as an evidence of dissemination in time. This patient is having an acute attack in this eye. Previously, has had an attack in the left eye. Now, the optic neuritis in atypical cases, usually severe vision loss. This eye is probably NPL, not done OCT. And as I said before, the superior and inferior quadrants are more afflicted in patients with NMO spectrum disorder, optic neuritis. The same 2 patients, the GCC scan, you can see in the acute case, it is orangish. The orange and yellow, I said, is very, very thick, healthy GCC, and it's not affected when the patient has got acute attack. But in the other eye, where we were suspecting some kind of past attack, the GCC is showing, yes, we were right, the patient has had some past attack. Now compare this GCC map of typical optic neuritis with the atypical optic neuritis. This is all around red. It is very severely thinned out all around, whereas here it is not a very bad affliction. Another thing that is seen in optic neuritis is a microcystic macular changes. You can see these small dark spots here in the inner nuclear layer, and they have been associated with severe disease as well as worse stability if the patient has MS optic neuritis, though they are more commonly seen in patients with NMO spectrum disorder, that is in 20% of these patients. Now let's see if the RNFL analysis can be used to diagnose tumors or monitor patients with cellular masses. Now, this is a patient long back. I've done this test where RNFL in the right eye is absolutely normal. Left eye showing some changes. And this patient had pituitary adenoma. Visual field is giving me much more information. In fact, this is not showing any change at RNFL, and the field is showing a hemianopic defect. So I will not rely on a machine which has only RNFL, not giving us GCC values, because it doesn't give us that much information, at least in cases of cellular masses, and that's what has been published. But the same cannot be said for the GCC. You can see that GCC for the same patient is giving me much more information than the visual field. Visual field here in the supranasal quadrant, if you look at it, you'll say it's kind of the function is preserved by the retina represented here. But if you look at the GCC, it's all washed out all around. And the hemimacular atrophy here kind of matches with the hemianopic defect that we have. So one can say that a hemianopia on perimetry can present as hemimacular atrophy and on the GCC thickness map, and hence can be used to monitor these patients, as we have done in this patient with pituitary adenoma. We can see that 2016, these were the findings. 2019, patient is maintaining the values, and we are not doing that regularly, the MRIs, because I kind of know that the patient's vision is preserved. Now, coming to OCT in patients with unexplained vision loss, where you have to differentiate between optic neuropathy versus maculopathy, especially outer retinopathies like azure, ellipsoid layer atrophy, etc., can be picked up on OCT very clearly, as you can see in this patient. Same thing, HCQ toxicity, foveal thinning photoreceptor, and RP atrophy can be picked up, but here you might have to do a multifocal ERG to literally clinch your diagnosis. Now, coming to an important topic, differentiating between papilledema and pseudopapilledema. 2014, when we started looking at the OCT in these patients, we noticed that in true papilledema, there's a hyporeflective triangular space, whereas in pseudopapilledema, they did not have that kind of hyporeflective space. They had a hyperreflective mass, which we call now forms. Now we have much more information, and we know we have picked up other biomarkers of true papilledema. You can see some microcystic spaces in the inner nuclear layer. You can see wavy deformity of the plexiform, outer plexiform there as well. You can see the indenting of the Brooks membrane retinal pigment epithelium complex, and you have to look at the reduction in the RNFL thickness, but it should be also associated with maintenance of the GCC thickness. If the GCC is thinning and the RNFL is also thinning, then your treatment is not working.
Ma'am, sorry to interrupt. You have 1 minute to go.
Yes, I'll sum up. So we've also looked at understanding, we've also looked at pseudopapilledema, where we found 3 important things. If you're suspecting pseudopapilledema, the patient will either have these druses, which can literally be seen as hyporeflective cent4 with a hyperreflective margin, or horizontal hyperreflective lines, or in children, just a nasal elevation with the forms. In congenital optic disc anomalies also, you can diagnose these anomalies on OCT. We've published a case where we could pick up peripapillary CNVM on OCT in a patient of morning glory. And you can see very beautifully the disc pit on OCT here. You can see the maculopathy, and I'll end my talk with the latest work that we are doing, that is looking at non-arthritic ischemic optic neuropathy on OCT angiography, which I haven't covered in this talk because of the paucity of time. And we can pick up the luxury perfusion on OCTA in patients of NAI. Thank you.
Thank you very much, ma'am. This was an excellent oversight on the very less understood aspects of OCT imaging in neuro-ophthalmic diseases. So I would like to request Vardha to carry forward with the proceedings.
Yes, so we will move on to our next talk. It's my pleasure to introduce Dr. Praveen Kumar Duvadhapare, who is an assistant professor at GMC Gondia, who has done his post-graduation from Chhatrapati Sambhajinagar GMC and DNB also. He has presented and participated in many national and international conferences and also published his research work in Index Journal. Today is going to present a case of IIH. Over to you, sir.
Hello. Good evening, all. Am I audible?
Yes, sir. You are audible.
Thank you. At the onset, I would like to thank you, organizing committee, for this presentation. I will directly start with the presentation by the case of idiopathic intracranial hypertension.
Praveen, you have 8 minutes to go, huh?
Yes, sir. So my case, my patient was a 36-year-old female teacher by profession. She had basically came for reflection for new spectacles with a complaint of eye strain in both eyes and intermittent blurring of vision plus minus bleediness. Since then, maybe more in evening time, but she was not sure. She was a known case of thyroid disease under treatment with endocrinologist on routine treatment with thyronome and multivitamins. For giddiness, she has recently checked blood pressure with physician, which was reported to be normal. At the presentation, after refraction, her best corrected visual acuity was near normal with low refractive error. Anterior segment examination was normal. This is how everything was being normal. Then, as a routine protocol, I started the central fundus examination, and this edema was visible without any pallor or no obvious hyperemia also. So later on, I moved who suspected a case of ischemia, very much color vision was normal, ocular movements were normal, contrast sensitivity was reduced by 1 line. For patient's past history, she had been 1.5 years back with routine similar complaint. At that time, her best corrected visual acuity was 6/6, and on routine, she was advised spectacles, their substitute multivitamin, and physician opinion for giddiness. But at that time, this was absolutely normal. So, other contrast sensitivity, color sensitivity was not done. With these things, with newly suspected disc edema, I advised her MRI, brain plus orbit, and routine basic blood testing, or maybe contrast report needed during MRI also. But at this point, patient was highly reluctant and surprised why I am advising MRI. So basically, patient went away, took second opinion, but ultimately the opinion was same from the other ophthalmologist also. So she came back whether that is really needed. I had to really consult patient, and ultimately patient so given option of taking neuro-ophthalm opinion directly also. The diagnosis, the findings and diagnosis were confirmed by the neuro-ophthalmologist. And at that time, MR venography with clear images were also suggested. Till now, patient had not done MRI. In the perimetry report, we can see enlarged blind spot in the left eye, and the parameters were fairly reliable. Then patient did the MRI. MRI suggested normal venography, but findings of empty cella and and bilateral optic nerve space fluids suggestive of benign intracranial hypertension. So basically, then by neuro-ophthalmologist, a neurophysician referral was sick, and the ultimate diagnosis was obesity with idiopathic intracranial hypertension. Patient was admitted. CSF manometry revealed pressure of 40. CSF drainage was done, and the biochemical markers were normal. Patient was admitted for multivitamin injection in a drip post CSF drainage, and ultimately was advised to start with tablet acetazolamide and Casol and B complex, and advised for weight reduction. In 1 month follow-up, patients all signs were improving, but patient suddenly had severe tingling and around face and fingers. So patient was reluctant to continue with the treatment and were doubtful. But the serum electrolytes were normal and understandings were slightly improving. So patient was again sought for a neurophysician opinion. Patient had reducing doses of acetazolamide and around 2.5 months. Except for acetazolamide, acetazolamide and topiramate, all other treatments were omitted. Visual fields also gradually started to improve, and by around 4 to 5 months, all ophthalmic parameters, examination as well as perimetry were normal. Actually, patient was asked by neurophysician to follow up after 2 months, and maybe at that time we can stop the treatment completely. But patient didn't follow up with the neurophysician. However, she visited to me at 9 months and 14 months with no active complaint, and examination findings were normal. But suddenly, at around 15 months from the first presentation, patient again had reported blurring of vision with giddiness of around 1 week. At this time, she reported early. Again, disc edema was present, and contrast sensitivity was reduced by 1 line. So at this time, I referred patient to neurophysician with perimetry reporting. However, patient did not do perimetry. At this time, patient took the neurophysician opinion from second neurophysician. He started her on n number of drugs, which apart from acetazolamide and he has been given gabapentin and all PCOD related drugs and multiple multivitamins. Meanwhile, patient actually had multiple episodes of URTI, asthmatic bronchitis, and for the first time, she mentioned that she had menstrual irregular bleeding. For this, she consulted gynecologist with USG report suggestive of thin endometrium. However, gynecologists also prefer not to give hormonal therapy in case of IIH. MRI brain was repeated at this time with almost similar finding. Endocrinologist also suggested to continue with the same treatment suggested by neurologist. However, patient suspected whether the multiple medicines are causing me these symptoms, and she again take opinion of the first neurophysician, who advised to continue the same treatment with reduced doses for around 2 months and to ask for follow-up. Now, patient is currently under follow-up with betterment than previous findings, and patient is supposed to review with ophthalmopedy with me and neurophysician after 2 months. To discuss with, so basically this case highlights the importance of fundus examination even in an apparently normal appearing cases. Whenever this abnormality is specifically this edema is visible, we need to see whether it is unilateral or bilateral. Retrospectively, sometimes we need to get into the history and other signs. Once there is disc edema, we need to differentiate between this optic neuritis versus other types of disc edema, particularly papular edema, and after ruling out everything, idiopathic intracranial hypertension can be labeled. Neuroimaging is very important in such cases. Routinely for idiopathic intracranial hypertension, modified Bandage criteria is suggested, in which the patient presenting with symptoms of raised ICT without any localizing sign, the patient should be awake and alert. CT scan, MRI findings should not be suggestive of any obvious other pathologies like space occupying lesion or venography suggestive of sinus thrombosis, and there should not be any other cause of raised ICT with raised intracranial pressure.
Dr. Praveen, you have to sum up, huh?
Yes, sir.
And it's almost over.
Okay. So risk factors are to be looked for. Only modifiable practically thing is omission of risk factors in heat reduction management is acetazolamide and topiramate. In refractory cases, can be neurosurgical procedure can be done, and multidisciplinary approach will be needed. So taking message from this case, fundus examination is must, and sometimes counseling is more important than our diagnosis in patients. Here, to the panel, I have one question: what is ideal duration of the therapy for idiopathic intracranial hypertension? Because whether that stoppage of idiopathic intracranial hypertension lead to recurrence. Thank you. Thank you for listening.
Thank you, Praveen, for finishing well in time. And we can quickly go on to our star speaker, Dr. Rashmin. I'm sure everyone was waiting for his talk. And over to you, sir. And I would like to ask Varda to introduce him formally.
It's my honor to introduce my mentor, Dr. Rashmin Gandhi, sir. He is a distinguished leader in the field of neuro-ophthalmology. He serves as the director of Cygnus LCC UAE Exxon MedTech Private Limited and Foresight Worldwide. He is also a consultant and director at Center for Sight, Hyderabad. Dr. Gandhi is a fellowship director and board member of World Headache Society. He's also a founding member of Indian Neuro-ophthalmology Society and a country director of Davos Alzheimer's Collaborative, that is a World Economic Forum initiative. He's actively contributing to global Alzheimer's research. He has held esteemed academic position, including professor and mentor at IIT Madras and IIT Hyderabad, and has been a clinical director for IIT Shankarnetralaya Mobile Eye Surgical Unit project. His remarkable contribution to research and education have earned him numerous awards, including an award for academic excellence presented by Honorable Shri Narendra Modi ji in 2011. Beyond his leadership, Dr. Gandhi has authored many books and scientific papers, delivered keynote lectures worldwide, and for over 2 decades, he has passionately trained residents and fellows, leaving a lasting legacy in medical education. So, over to you, sir, because I think this talk we don't want to miss.
Thank you, Vardha, for that very kind introduction. I would like to thank Vidarbha Ophthalmic Society, GOA, for this invite. Congratulations, VOS, for your Golden Jubilee year, and congratulations, GOA, for your first combined webinar. So we are going to talk about a few patients' diagnostic dilemma, which can present to our comprehensive ophthalmology OPD, where under the cover of very innocuous-looking symptoms can be a fairly serious, sometimes fatal, potentially fatal neuro-ophthalmic disorder. And I have divided into 4 different cases, signifying the importance of history, visual acuity, pupil, and glaucoma. And we'll see how much of these we are able to cover in 12 minutes. So the first patient, and I would like to acknowledge Dr. Naveen Jaikumar, who has shared this patient with me. This was the patient who came with a history of repeated hit on the head 6 months ago. And he said that after that, his eyesight gradually went down. He was told locally that he has traumatic optic neuropathy in the right eye, and nothing really can be done for that issue. So he came for a second opinion. When he came for a second opinion, his fundus looked like this, very clear optic atrophy on the right side. However, what was missed out in the first treatment when a patient presented to the first team was even a bow tie kind of optic atrophy on the left side, because there was an impressive optic atrophy of the right side and patient's symptoms were focused only on the right side. This was missed out. What was the other thing which was missed out is this gradually progressive loss of vision, which is very rarely a feature of traumatic optic neuropathy. In the setting of trauma, unless you have a fracture of optic canal with the bone impinging on the optic nerve, generally the vision loss would be acute. Only when the bone is pressing on the optic nerve where you will have a gradually progressive loss of vision. And so patient underwent MRI scan, and patient actually, this is just a representative image, patient actually had a pituitary tumor, and the trauma was just the incident. So what we learned from this case, what was missed out? First thing, history. Any gradually progressive loss of vision has to be chased, even if patient has an optic atrophy, because now the vision loss is progressive, implying that the disease process which led to vision loss is still there and has to be chased. Now, second case, visual acuity. This was a patient which we saw in Chennai, where a patient in a presbyopic age group came saying that I'm not really able to read too well. And he had actually changed multiple near vision correction in the last 2 months, and he was not very happy. So his persistent problem was, whatever glasses that I read, I'm not able to read too well. And a very smart optometrist at Shankar Netralaya figured out that this is not really just presbyopia. So she went ahead and did the Amsler charting just to make sure that everything is all right. And what was found is, again, a representative picture, and this is a little wrong, but that patient actually had hemiscotoma, homonymous hemiscotoma, because of a tiny little stroke in the occipital lobe. So patient's visual problem was not related to refractive error, but because of that, he was not able to initiate reading too well because there was a hemiscotoma which was sitting right next to the fixation. So we need to make sure that when innocuous problem in a presbyopic age group can still be hiding something sinister. Now, this is a third case. A 34-year-old female, she came with sudden painful loss of vision in the right eye. She complained of a little bit of headache with eye pain. She came last year. This is how, and I'll just let you read through this examination finding. She was seen with this kind of examination finding by a retina clinic. And this is how the optic nerve looked like. There is a very clear optic disc swelling. So here is a young female, acute loss of vision, complaining of eye pain, having a disc edema. It was thought that maybe this patient has optic neuritis. Patient was referred to let me first ask you as to what should we do. And then patient underwent MRI parietal and orbit with contrast. which came back as saying maybe there is some hyperintensity, maybe there is optic neuritis. There were no lesions on the brain. So at this point, what can be done? Should we give IV methylprednisolone? Can we give oral prednisolone, or can we just watch this patient? So one thing which is clear, when you have a suspicion of optic neuritis, don't give oral prednisolone to start with. So patient either can be given IV methylprednisolone or watchful expectancy. The general trend now is, because of these new, relatively new disorders, which are optic neuritis mediated by antibody, we should be giving steroids to everybody whom we suspect as having optic neuritis. So patient was given steroids at the neurology clinic, and patient within 2 doses, neurologist called back saying that patient has a dramatic visual improvement, and she's saying that vision is great in both the eyes, and that's it. A neurologist took over the management of the patient. Patient was given steroids for a little longer period of time. However, around 3 months, patient was given steroids by neurologist, oral tapering steroids. Patient came back after 3 months saying, now my vision has gone down, my steroid is being tapered. Neurologist thought that maybe there is a recurrence. Patient was referred back for examination. Now you see that there is no disc edema, but you can clearly see this dirty looking membrane just in a juxtapapillary region. So actually patient turned out to have a tubercle choroiditis, which was missed out. So this is a picture when patient came 3 months prior to this episode. So then went back to the history, and we found that patient had disc edema, but there was a bilateral problem. There was some vitreous cells and pigments on the interlens, which was mentioned actually, and optic nerve dysfunction was mild, and there was an impressive and very quick steroid response, which were all pointing towards not really an optic neuritis and not a typical optic neuritis. Was there something which was missed out? Let me show you the picture. And you can say here, while patient's visual acuity was 6/36, but optometrist had clearly mentioned that she was not very clear about presence of RAPD. And patient was seen dilated. So very important here, and that's why reason I said the doll that didn't bark. Doll means pupil. So here we want to make sure that any patient where we suspect a unilateral optical problem, you need to demonstrate, irrespective of etiology, you need to demonstrate RAPD of that side. There is no RAPD, it's not an optic nerve problem, or it is bilaterally symmetrical optic nerve problem. This is very important to note, because the entire management of this patient changed if that query RAPD or no RAPD was noticed right in the first step. Probably that patient would have been evaluated a little more, and patient would have we would have found those vitreous cells and pigments on the lens right in the first line itself. So we are talking about visual acuity. There is one more patient, again complaining of near vision problem, a 34-year-old female. But you find here, this is the other neuro-ophthalmic problem which can present with just a near vision problem. You can see that patient has anisocoria with left pupil being larger than the right pupil, and this pupil actually constricted when we put a diluted pilocarpine on the left side. So apart from that hemiscotoma that I showed you, patient with AD's pupil can also present with near vision issue. Now, since we are on pupil and anisocoria, let me show you one more patient. This is a patient which presented to Dr. Akshay Gopinath Nair in Bombay. A patient was referred to Akshay Nair for management of involutional ptosis of the left side. Patient was diagnosed with involutional ptosis, and patient she was referred to Akshay for treatment of this. However, as Akshay is well trained by Shikha, Ambika, and all team at SN, he looked at the patient carefully and found that actually patient has a very small pupil of the left side, anisocoria, which was worse in the dark, implying that patient actually was having Horner syndrome. He went ahead and did the investigation. The patient actually had Pancoast tumor, which presented with Horner syndrome to the ophthalmologist. One more case, patient who had a severe road traffic accident with whiplash injury of the neck. 3 days ago, she lost glasses and she presented to the ophthalmology clinic, thinking that maybe her headaches, which she was having since accident, and the neck pain is related to the glasses that she lost. And here, this is a representative picture. Would like to acknowledge Dr. Devendra from Bombay, who gave me this picture. You can see there is a very mild ptosis of the left side. However, if you look at the patient carefully, you find there is an anisocoria, which is much worse in the dim light, implying again that patient has Horner syndrome. Why you don't want to miss this? In the setting of trauma in a young patient and a trivial trauma in old patient, if patient has an acute painful Horner syndrome, patient might actually be having carotid artery dissection. And remember this this paper by Valerie Buse said that 50% of these patients actually present to ophthalmologists, and this patient can have stroke or even MI anytime. So this can be potentially fatal problem presenting to ophthalmologists, and 60% of these patients can have permanent neurological damage, 5% mortality rate, and that's the reason why you don't want to miss out on anisocoria, especially painful Horner syndrome. So if you have a Horner syndrome, patient complaining of pain, try to localize where the pain is more. Patient has facial or neck pain, maybe you're looking at carotid artery dissection. Patient has mainly shoulder pain, which is subacute. You're probably looking at Penco's tumor and periodic cyclical headache with Horner syndrome. You do MRI brain, maybe you are dealing with trigeminal neuralgia. This is the last segment of science that you don't want to waste. We looked at the history, visual acuity, and pupil. Now let's see what is the interplay of glaucoma. Glaucoma is an optic neuropathy. It's just that we know that the risk factor is in the eye and not in the brain. However, there is a separate group of disorder which I feel is very controversial, is normal tension glaucoma, where there can be some kind of neurological or neuro-ophthalmic overlap. 70-year-old male with poor vision in the left eye, and this is how the optic disc looked like. He was being treated as a patient with glaucoma. If you can see here, though there is a large cup, but you can clearly see that the neuroretinal rim is pale. So whenever you have a neuroretinal rim which looks like this, which is pale, you know that you might be dealing with a cupping, which is because of a neurological disease. What should we do next? Again, as I said in the first few cases, pupil. RAPD is an objective test for unilateral optic nerve disease. The question is, can glaucoma lead to RAPD? Well, this was this paper by Brown et al., which said that you need to have a mean difference of cupping of at least 0.4 between two eyes before glaucoma can be a cause of RAPD. So in other words, you have glaucoma, asymmetric glaucoma, but the cup difference between two eyes is not 0.4, then you probably, and patient exhibits RAPD, you probably are looking at optic neuropathy, which is not because of high intraocular pressure. So other important simple test to do is color vision. Color vision is mediated by papillomacular bundle, which is not really affected early in the course of disease. Glaucoma is the disease process which affects the arcuate fibers. So if patient has dyschromatopsia and has been diagnosed as glaucoma, maybe you're looking at non-glaucomatous visual acuity. And I will end with this paper, very beautiful paper, which was done by, which was published by our friends at SN, Ronnie George, Nikhil Chaudhary et al., where they looked at 6 patients of glaucoma, 6 patients which were being treated as glaucoma, but during follow-up turned out to be a non-glaucomatous optic neuropathy. And they looked at what was missed out, and what was missed out was really glaring. You know, things like failure to document morphology of pupils in all 6. So if the pupil morphology was documented, maybe some of these cases would have been picked up because of the presence of RAPD. Failure to document optic disc morphology besides just the vertical cup dysplasia. So if you had looked at a neuroretinal rim, you probably would have seen a pale neuroretinal rim in many of these patients. Failure to correlate visual acuity with the optic disc, and failure to obtain visual field examination in half of them. And other half where we had obtained the visual field, it was misinterpreted. So in other words, pupil, visual field, proper history, correlation of clinical picture with what's going on are very important in these cases. So these are the signs that you don't want to miss, because something which is innocuous, something which is seen in day-to-day life, sometimes can end up having some of these problems. I thank the entire team once again for this very kind honor.
Thank you, sir, for an excellent and enlightening cases. And we have been always amazed to watch all your interesting cases. Thank you so much. I would like to request the panelists. First, we'll take the panel discussion on interpretation of visual fields in neuro-ophthalmology by Dr. Nilesh Jain. Is Garima over there? I think Garima is not there. So maybe Jain. Dr. Mohan, is he there? Yeah, Dr. Mohan, are you still there?
I think we can start the panel discussion. We have one question also by Dr. Neeta Kumari. She's asking about, is it necessary to do serum electrolyte in patients with IIH who are on tablet Diamox, and at what interval?
So Dr. Shikha, can you take this question?
Unless the patient is symptomatic, very severely symptomatic for potassium depletion, usually we do not order serum electrolytes, and you supplement with patient is advised to have potassium supplements along with that. Patient is treated at Chinkanetrale for IIH by a neurologist, and all this monitoring is done by neurologists, and unless the patient is specifically complaining of severe dysthesia or anything, it's not routine. It's not routine to order for. At least I don't order it that in my clinic.
No, I agree with Dr. Shikhab on both points, and this is very important, I think, for all of us to understand that while the process involves the optic nerve, so the patient presents to us, but the disease process is actually in the brain, which is better handled by neurologists because there are different implications. And our role is to make sure that the optic nerve, the vision is preserved, and we report to neurologists saying that, you might be aggressive or maybe a surgical treatment is important. And I agree that, I don't think potassium level, especially with the dosage that we give, is necessary.
And I've seen that the patients tolerate Diamox pretty well for sufficient length of time. I mean, patients are on Diamox for about even 1 or 2 years, and they do tolerate Diamox very well.
Just a small mention that since we have a glaucoma setup and Dr. Nangia is there at our institute, so we have seen patients tolerating Diamox for almost decades.
I just wanted to ask one quick query to Dr. Ashwin. Can there be a perioptic swelling on MRI? MRI reports a perioptic swelling, but no papilledema.
Yeah, so that's a very very tricky situation where clinically it's borderline. You don't see any obvious disc edema, but the MRI will come back with one of the following. MRI will say partially empty cella, widening of perioptic sheath. Now, I personally believe that you treat the patient and not the neuroimaging. However, there have been a group of neurologists who believe that manifestation of the pressure transmission from the brain to the optic nerve can be, and we know that it can be affected by the local factors. And they have been, and I know that group in Bangalore have been relying on ultrasound to say that even if there is no overt disc edema, can we rely on ultrasound and treat these patients? I personally feel our job in these is to say that whether optic nerve function is normal and is optic nerve function is stable. Now, if you find these two, I don't think we need to recommend any treatment, but I'm happy to hear from Shikha if there is any other view.
Sir, one question: how long usually, though the cases are being treated by neurologists, but how long usually this oral treatment should continue?
Yeah, so there is no clear algorithm or well-defined period saying that 3 months and you stop it. It is absolutely patient dependent. What are you establishing? You are establishing one disappearance. What are you treating? You are treating disc edema and a potential optic nerve dysfunction. So you need to make sure that both these have stabilized, that the disc edema has reduced and has now not come back, and that the optic nerve dysfunction, if there was a dysfunction, has reversed or again stabilized. Please remember, more and more papers are coming up now to say that actually IIH, especially IIH, is a metabolic disease, and raised ICP is one of the manifestation of a metabolic disease. So much so that apart from, we know that patient, one of the most important hallmark of this treatment is the patient should lose 20% of the presenting weight in next 4 to 6 months. Now, so much so because of this definition of this being a metabolic disorder, a lot of Western countries have started advising bariatric surgery for these patients to say that there should be quick loss of vision. But conclude to say that is there a clear algorithm to say or a clear dictate that it should be used for a month, 2 months, 3 months? No, it is patient dependent till the anatomy and the function stabilizes.
So,
I would like to ask one question here with respect to Dr. Praveen's case. There was a recurrence of papilledema. So IIH came after despite stopping the treatment. So what are the investigations mandatory? Because I have seen few in my patients that weight increase and anemia are very important reason for recurrences to happen. So and how frequently should we be doing MRI in such cases?
Chicago.
So, obesity is not that much of a risk in India. As you pointed out, anemia, PCOD, these are more commonly seen in our group of patients. You have to do, it's again patient dependent. Patient has come and you will typically look at the age group, and we've had different causes. I've had a patient who's taken, vitamin A creams, that vitamin A supplements and cream. You have to ask, then because of that, she's developed IIH. Sometimes it's the pimples treatment. So if it is a specific cause, which is, an external cause, extraneous thing, you stop that and patient is fine. But if it's anemia, it's PCOD, it's not something from outside, and the cause of IIH is multifactorial. There is a problem in the brain. There is a problem with the flow, and then there is a second hit because of it could be any other cause. So the second cause, that if you've identified, you've ruled out, that I've got this, like vitamin A, or some toxicity, or it's because of the drugs, then you stop it, your patient is safe. But if it is things like anemia and PCOD, it can come again. You can have a recurrence. You need to keep these patients on a follow-up.
I have one question. Actually, as a practitioner, one of the commonest neurological symptom which patient usually comes to us is headache. I want to know, the headaches come in variety, different tarah ke headaches they come. Which headaches do you feel that we should investigate further, or so that we not miss out on certain important neurological problems or neuro-ophthalmological problems?
When you say investigate further, what do you mean?
Visual fields and imaging.
Yeah, every headache can have a visual field if the patient can afford. I think there is nothing wrong in doing a baseline visual field. If the patient has come to you for headache evaluation and you have some amount of neuro-ophthalmic practice, then visual field is definitely a part of it. Color vision is definitely a part of it. You shouldn't miss things like you can have pituitary adenomas presenting with headaches. So you can, pick those up on very rarely. I remember, long back there was a case. Patient was totally fundus, was fine, 6 everything. And patient come for headache, had a bitemporal on fields, which was done for headache. These are rare situations, but I think there is nothing wrong in getting the visual fields done if the patient can afford. And more than the visual fields, if you haven't, usually I order for orthoptics if I think that the patient, is complaining of headaches. Find out a cause for aggravating factors for headache. And depending on that, you involve a neurologist. You may not need to do MRI, but the 3 things in your headache practice is visual fields. You do your color vision, visual fields, and if required, orthoptics, and keep the neurologist in the loop, I think. Because migraine is one of the, if there's no papilledema, migraine is another thing that's better treated by a neurologist. Sir, RAG, sir.
Absolutely. I think our job is to make sure that there is no ocular cause of headache, number one. And number two, as Shikha mentioned, visual fields, I would say, is must, because you don't know what you will pick up, and it's such a simple test, and it should not happen that we missed out. As she said, there have been instances where subtle defects have been missed out. So formal fields, and if you feel that it's not something which is very severe, at least a confrontation, at least to make sure that you write down that there's no red saturation in temporal part. But I would suggest that if formal fields is not otherwise contraindicated from the social perspective, go ahead and do it.
So I have a question to Dr. Basi. Ma'am, like as you told about the OCT in neuro-ophthalmology, so I just have a question, like if patient is having optic neuritis and we are doing the MRI scan to rule out any MRI plaques in the neural plaques is there in the optic nerve or in other part of the brain. So is it important to go for OCT also for these cases?
No, I mean, it depends on what kind of neuro-ophthalmic practice you have. If you are you're not going to refer the patient further on for treatment to anyone, and you are the key person taking decisions whether the patient's, what is the immunomodulation or immunosuppression that is required for the patient. Now we have so many kinds of atypical optic neuritis. Every little bit of information regarding what kind of optic neuritis it can be is very valuable, because a MOG optic neuritis needs a different kind of immunosuppression compared to NMO disease, compared to MS optic neuritis because of sarcoidosis. And the more you see these OCTs, the more patterns you detect, small little clues about what could be the cause of this atypical optic neuritis, which can, kind of guide you towards how to further on manage. See, optic neuritis is not like you treat it once and then you're done. The patient is with you for life, The patient needs to be first, the patient needs to be got off the steroids by managing immunosuppression. Second thing is the patient needs to be periodically checked whether without the patient's knowledge some activity is happening. So I think for all these things, if you are the person taking charge of the patient, it will be really valuable.
And as Dr. Basi said very nicely, that we should be doing optic neuritis OCT even in cases of suspect optic neuritis, because please remember, if the optic neuritis, though patient has a unilateral problem, but if it's because of some systemic disease, either in the brain or in the blood antibody, you may find subclinical RNFL thinning in the other eye. Patient may be asymptomatic, but you will find that there is a significant thinning in the other eye, which tells, for you to tell neurologist that, it looks to be a bilateral problem, so patient is complaining in one eye. I mean, that's it. And as she said, that for follow-up.
Should we always do a macular
GCL.
GCL along with optic nerve?
Absolutely. As I said, that for monitoring the vision, both the acuity and the visual fields, it's the GCC that gives you the information. We cannot have a neuro-ophthalmic OCT without GCC. RNFL can be very misleading.
Thank you.
Just a small comment from my side, that how to differentiate between a GCC loss because of a neurological disease or a glaucomatous disease is that the GCC loss in neurological disease will be the nasal side, and in a glaucomatous disease, the GCC loss will be more on the temporal side. And also similarly in RNFL, you'll have a three sectors which are on the temporal side that will be thinned out, especially in a neuro-ophthalmic disease.
Okay.
So I think we are almost at the end of the session. Rahul, you want to give the closing remark?
Yeah, I just want to ask one question to Shikha madam. Like what are the signs you will see in a OCT when you monitor a diagnosed case of papilledema, or how is it important as a tool to see disc on the OCT or GCC for that matter? What are the signs that we see when we follow a patient on papilledema? Because many times, if there is no specific occupying lesion in the brain, and it's a case of raised ICT or idiopathic intraocular hypertension, so the neurologists keep the patient on either a Diamox for a longer period of time, or they just do sequential lumbar punctures or so. So how do we, as an ophthalmologist, can help the patient or neurologist by monitoring the patients with the OCT particularly?
Yeah. So as I said, the aim of OCT is to capture data. You're capturing data. Previously, the same data was being captured in forms like glaucoma specialists know that we used to take disc photos, right? Basically, when the patient has presented to you and after treatment, patient is going to come, either you make a very elaborate drawing or you take disc photographs so that on your follow-up, you have the previous record. You've captured the data. Now, with the OCT, you're going to have the contour of the disc on EDI OCT, or even if it's not EDI, whatever cross-section you're getting, you have the contour, how the disc is looking, whether, it's going like this, the RP and that complex is going off the outer thing is that is seen in extremes of cases. I don't rely that much on those figures. What is important is the RNFL thickness. You have the average RNFL thickness in all four quadrants. That's a value which can be compared. Now in OCT, I didn't go into the details like things like repeatability and reproducibility. Repeatability is that when your ophthalmologist, you do the OCT, you're doing it today, you're doing it tomorrow, you're going to get the same result on that machine. That has been proven that it's very reliable, it's repeatable. Reproducibility is you've done on that machine, somebody outside, you've referred to me and I do it, it's going to be again comparable. I can take what value was, documented by you and compare it with, so for most of the machines, repeatability, reproducibility has been proven. So now I have captured the data. I've kept that now at the onset of treatment. The RNFL in all four quadrants is this much. There is a value given. It's gone into 400, 500. I know it's a very bad disc edema. Next time patient comes, it's gone to 300. And it's a good signal. You've ruled out artifacts and stuff, and it's gone to 300. I can tell my neurologist, see, your treatment is working. Send the patient after a month. Let's see. It's come to 200. I say, yeah, wonderful, it's working. But I need to look at the GCC also. If the GCC is nice, usually in papilledema, when the patient presents in acute cases, so much of thickening around, you don't get very good values in GCC because there might be a lot of peripapillary edema going till the, if there are a lot of hemorrhages and things like that. Once it starts settling, the usually ganglion cell layer is maintained in papilledema. In fact, the kind of papilledema that is seen in US because of obesity, which is a very subtle papilledema in IIH patients, there was the initial, thought that GCC is not affected at all in IIH. So you don't need to monitor it, but that's not so for our patients. We see very severe cases where, it's not that obesity-related subtle papilledema. We see a lot of cases of fulminant papilledema. So there, once it settles, there can be some changes in the GCC. All you need to monitor is that GCC is not worsening from what you have recorded in the initial duration. So RNFL should come down, GCC should remain same. This is what you have to monitor when you're monitoring patients of IIH.
Okay. Thank you, ma'am. One more question, like how frequently you suggest to repeat the OCT? Like in case of macular edema, we see it every month. So here in cases of papilledema, when we monitor the GCC and RNFL, how frequently?
Yeah, so the frequency depends on, see, if somebody's got fulminant papilledema. it's like fulminant IH patients losing vision, patients going counting fingers and all. You're going to monitor very, very closely, right? So it depends on the severity of disease. If you think that things are under control, you can monitor. The patients just has subtle peripheral constriction and a little enlargement of blind spot. You can monitor monthly. Or maybe, we see outstation patients. Sometimes we ask them to take treatment 2 months and then, show locally once and then come to us 2 months later. So how much control you're feeling that the patient shouldn't lose vision. If the patient is under your care, so it's like in any ophthalmic disease, you monitor it more aggressively, the more aggressive the diseases, and you can have a variety of presentation in IH.
Sir, a question for Rashmin sir, please. What is your preferred line of management for a diagnosed case of non-arthritic ischemic optic neuropathy, sir?
So there are a few things here. Non-arthritic AIN, the most important point is that you want to save the other eye, which is your first primary. Second, you need to take care of the vasculopathic risk factors, which will again save the other eye. Vasculopathic risk factors, the known one are hypertension, the commonest, diabetes and hypercholesterolemia. Please remember, in young patients, hyperhomocystinemia. Everybody, patient need not be obese. He or she can still have obstructive sleep apnea. And the medications, like in male patients, Viagra, amiodarone in patients with cardiac problem. And now we're not very sure, but Ozempic, drugs like Ozempic seem to be producing the syndrome, which is like AIN. We don't know because patients who are in Ozempic are also likely to have vasculopathic risk factors, but we need to take care of these. So the question you are asking is, what is the role of steroids? What's the role of anti-VEGF? Because these are two ones which are tried. Steroids, systemic steroids or intravitreal steroids have been tried. No clear evidence to say it works, right? There is only one study which was done by Sohan Singh Here, where the steroids, which was done in 2008-9, where he found that the steroids, if given in first week or in first 10 days, would have a beneficial effect. However, there were a lot of sampling error in the study and the way patients were chosen, because it was patient choice study. Patients were given a choice, would you like to take steroids or not take steroids? And patients were explained about the side effects of steroids. So the severe ones anyway would get eliminated. So in other words, we don't know really whether steroids work, whether systemic or the topical steroids work. Topical, I mean subtenance or intravitreal. But we know that, or how I have seen or what I practice, is if patient comes in the first week, and if physician agrees for a protracted course of steroids of around 4 weeks, I go ahead and give steroids. Now I have had, in my limited series at Center for Sight, I had all three results. I had patient who came back after 1 week with improvement in disc edema, with minimal improvement in visual fields, patient stabilizing, and I had had a patient who was on steroids given somewhere else for AIN in the other eye, while the steroids were being tapered in third week, had AIN in the other eye. So we don't know, but the first week I end up giving oral steroids. In non-arthritic AIN, I don't give systemic steroids. There is no role of intravitreal injection, including anti-VEGF. In fact, please remember, anti-VEGF or intravitreal injection itself is a risk factor for production of AIN, and anti-VEGF can have an additional, especially Avastin, can have additional neurological side effects.
And what is your regime of giving IV methylprednisolone? Like you give it for the 3 days or 5 days in a case of optic neuritis, sir?
So again, as Shikha said, most of these are managed in conjunction with neurologists. The neurologist that I work with he believes that it's good for our patients to give it for 5 days. In fact, sometimes they end up giving 1.5 gram and not 1 gram. Of course, we cannot really say whether it works or doesn't work because we don't have any comparative study. But our neurologist generally ends up giving for 5 days.
No, let's see.
We have seen patients who unfortunately, even after controlling hypertension and other factors, have similar complaints in the other eye. My patients after 2 years, 3 years have come with AION in the other eye.
Yeah, unfortunately, I think only thing, because a lot of these patients probably just have a problem with their autoregulation. So it's an autonomic nervous system problem where autoregulation is faulty and there is nothing much that you can do about it except that you control the vasculopathic risk factors and hope that if there is no fluctuation which can lead to a problem. Because if autoregulation is faulty, even minor fluctuation of blood pressure can trigger AIM.
Just I will like to add one point in IIH. Just
Please, ma'am, go ahead. Go ahead.
I think our connection is little.
Connection is.
Gandhi sir, after giving five days of intravenous steroids, are we following the oral doses for the 7 days or something like that?
No,
No?
now our neurologists have stopped giving oral steroids altogether, if at all. Now, because they are much more scared, and rightly so, about antibody-mediated. Is it NMO? They are much more aggressive about antibody-mediated optic neuritis. So a lot of time uh, they counsel patient for the need of steroid sparing agents like azathioprine, and if they have to go higher, rituximab, and then they monitor it because each one has an duration of onset of effect. So sometimes they cover up that duration with steroids and then move to as I said, the couple of groups that I work with, one group is actually fairly aggressive even with flex. So even the suggestion that the patient may be having NMO, they go very aggressively early in the disease with the plasma.
Do you feel this rituximab, etc., have improved the prognosis in certain patients?
We can say that probably it stabilizes the deterioration. It reduces the recurrences, and the more importantly, it would have reduced the chances of spread, paraplegia, and other neurological problems.
Especially in mild optic neuritis, rituximab has a role.
And similarly, in IIH patients with Dimox for a long time, have you noticed ototoxicity? I have one patient like that.
Not really. It's a possibility, but I haven't seen any patient. Patients can develop renal stones.
Yeah.
That's a possibility.
Sarang, if time allows, can I ask one last question to Lakshman sir?
Please go ahead.
Yeah, sir. Basically, the pathophysiology is not clear for the papillitis and non-arthritic ischemic optic neuropathy, both being the dysregulation of microvasculature. The other non-arthritic ischemic optic neuropathy, basically the posterior ciliary artery supply is getting compromised due to vasculopathy. But in diabetic, again, there is microvascular dysregulation. We don't know the difference, but probably there is a difference of ischemia in one. And in other case, there is no ischemia. So is there a difference in the treatment of papillitis versus NAION? Like NAION, you said that anti-VEGF periocular or intravitreal is contraindicated. And how about papillitis?
Diabetic papillopathy. I think what you meant is papillopathy.
Yeah,
not
diabetic
papillitis. Yeah, because papillitis obviously is a different connotation.
It's optic neuritis. Yeah.
Yes. So diabetic papillopathy, there is a thought process that maybe it is a precursor to NAION, but we don't see all of them go ahead and do NAION, number one. Number two, it is more in type 1 than the type 2 diabetes, diabetic papillopathy. And there is a very high possibility that the optic nerve function would be normal in papillopathy with just a disc edema there. And if at all, if the vision is lower, is more likely to be because of the macular involvement and not because of the optic nerve involvement. So unfortunately, there is no treatment that comes to our mind which we can institute to say that this will not progress, if at all, to NAION. One thing which may guide you, however, is that please remember, and this is something which our mentor, Dr. LG, always used to say, that in a suspected or in a diagnosed case of NAION, look at the other eye. If the other eye has a normal disc with a normal cup, think of something else. Because you need to see a small disc with small cup to make sure that you are dealing with NAION. I mean, of course, there can be a small number of cases where because of dysautonomia, maybe even with a normal cup, you can develop NIOD. But so that's something which may guide you, saying that papillopathy can develop in everybody or anybody which has a diabetes and especially type 1 versus NIOD where you need to have this complete package to say, yeah, this is NIOD. So I would say that if somebody where we diagnose as papillopathy has a discat risk in the other eye, maybe we need to be aggressive to treat with whatever we have, like sleep apnea and other risk factors.
So any role of steroids, periocular steroids or intravitreal anti-VEGF in this
Not that I know of.
papillopathy?
No, not that
Okay.
that I know of, because I don't expect them to have a severe or even mild optic nerve dysfunction.
I would like just to add one point regarding IH.
Yes.
Yes. Besides all these important risk factors like obesity and hormonal disturbances, important history of taking some drugs is also very important these days, because many this group of young girls are taking skin treatment. So tretinoin, a tetracycline group of drugs, and sometimes antidepressants also, they also cause IH. So this history of taking some drugs is very important in such patients, besides I think hormonal disturbances and obesity. And another, I would like to ask one point, like nowadays OCT in neuro-ophthalm, like Alzheimer's and Parkinson's also, they are showing changes. So do they refer to you for OCT, or do they correlate neurophysicians
No,
with the OCT
not
finding?
Not really. Not really, though OCT in Alzheimer's as well as in Parkinson's, there are enough and more papers to show that degeneration that is occurring in the brain is being reflected as thinning of both RNFL and GCC, and it's being correlated with the disability. And a lot of work is being done. But unfortunately, for the diagnosis, we're not yet getting a process for that. But we are looking into it. We get a lot of patients of Parkinson's who are, being monitored. We are studying at the looking at the parameters.
There
And
has
it's
been
already been published that there are a lot of papers already. But no, it's not being used as a tool yet by the neurologist. At least they're not referring to us.
and there has been a special retinal photograph, a special technique of taking a retinal photograph where they have demonstrated the amyloid plaque on the retina on fundus photography. However, now the whole hypothesis of role of amyloid in Alzheimer itself is in question, whether it's the amyloid is the cause or the effect of what is going on in the brain. So, as Shikha said, that while we see the changes, but can they be used as a biomarker? I think we need a very large study to say that, yeah, it is a biomarker which mimics, and you don't require a PET CT, but you can do OCT and talk about what's going on in the brain. But we have not reached there as yet.
Yeah, that was an excellent discussion on neuro-ophthalmology, I think. Rahul, we can
Yeah.
close now.
Farid, yeah. So thank you so much, Shikha madam and Rashmi sir. We're grateful to Gondia Ophthalmic Association, and I request Shamik sir to complete the vote of thanks.
Thank you, Rahul. At the outset, I would like to congratulate you and the whole of the scientific committee for organizing a well-curated webinar today. On behalf of VOS and Gondia Ophthalmic, I would like to thank and give deep regards to our esteemed national faculty, Dr. Rashmin Gandhi sir and Dr. Shikha Basi madam, for their very nice presentations and valuable expertise that truly enriched our understanding of complex conditions in neuro-ophthalmology. A special thanks to our very own VOS faculty, Dr. Jain sir and Praveen, for their perspective and engaging discussions. which made this session all the more meaningful. And equally thankful to all the chairpersons, moderators, panelists who took out time for from their respective schedules for this webinar. Sincere thanks to Entot Pharmaceuticals and technical teams for their generous support and collaboration in this for this webinar. And lastly, I'd like to express my appreciation to all the attendees for taking out time and making this webinar a success. Thank you everyone once again, and please do block your dates for the 50th annual conference of the VOS to be held at Nagpur on the 10th and 11th of January 2026. Thank you. Over to you, Rahul.
Thank you. Thank you so much.